Iron is an essential element of hemoglobin and red blood cell homeostasis. However, iron remains a significantly and potentially deadly cause of metal poisoning. Toxic doses of iron overwhelm normal gastrointestinal regulatory mechanisms and can lead to massive iron absorption. The pathophysiology of iron toxicity can be divided into two mechanisms: corrosive and cellular. Iron is directly corrosive to the intestinal mucosa and causes mucosal irritation, ulceration, and bleeding. While on the cellular level, iron causes mitochondrial dysfunction and impairs oxidative phosphorylation. Iron toxicity is manifested as both local and systemic. Iron has effects on the gastrointestinal system, cardiovascular system, and on the central nervous system.
Iron can cause ulceration, bleeding, edema, and perforation. Multiple cardiovascular manifestations of iron excess are more evident on the heart and blood vessels, which manifest as post-artery dilation and decreased venous tone, while the effect of iron in the liver is manifested in the Kupffer cells of reticular endothelial system and causes swelling of the hepatocytes, portal iron deposition, fatty metamorphosis, and massive peripheral necrosis. Iron can also produce cerebral edema, which manifests as lethargy, coma, and seizures. Before we discuss the clinical manifestations of iron toxicity, let us first look into the range of toxicity of iron excess. Ingestions of less than 20 mg per kilogram of elemental iron have little risk for toxicity and require no specific treatment, while ingestions of greater than 60 mg per kilogram of iron has been associated with serious toxicity. Death from iron toxicity has been reported with a wide range of 60 mg per kilogram to 300 mg per kilogram of elemental iron. So how is the amount of elemental iron ingested known? Elemental iron is computed by multiplying the percentage of elemental iron in the preparation by the total amount of ferrous salt ingested and is divided by the total body weight of the patient. The most common preparations for ferrous are ferrous fumarate, which contains 33% of elemental iron, ferrous sulfate, which contains 20% of elemental iron, and ferrous gluconate, which contains 12% of elemental iron. The clinical presentation of acute iron toxicity has been traditionally divided into 4 stages. Stage 1, or 30 minutes to 6 hours after ingestion, or the gastrointestinal phase, is characterized by nausea, abdominal pain, vomiting, and diarrhea. Local corrosive effects may result in hematemesis, hematochezia, and melena. Stage 2 is 6 to 24 hours after ingestion and is sometimes referred to as latent or quiescent period. It is characterized by transient GI symptoms and subclinical hypoperfusion and metabolic acidosis. Stage 3 happens 12 to 48 hours after ingestion and is referred to as systemic toxicity. Recurrence of GI hemorrhage, hematemesis, melena, and bowel perforation may be seen. Acute circulatory shock may also be present and is characterized by tachycardia, tachypnea, pallor, hypotension, and cyanosis. Stage 4 is 4 to 6 weeks post-ingestion and is referred to as bowel obstruction. Patients may go into chronic outlet obstruction or pyloric stenosis as a result of GI scarring. For the diagnosis of iron toxicity, the serum iron concentration is useful in confirming an ingestion and may be useful in predicting serious toxicity only if blood samples are withdrawn at appropriate time. The most valuable time to assess the potential toxicity with an iron concentration is 4 to 6 hours after ingestion. Serum iron concentration of less than 300 microgram per deciliter are associated with little to no toxicity. Concentrations greater than 500 microgram per deciliter are associated with definite serious toxicity, and concentrations greater than 1,000 microgram per deciliter have resulted in death. On the other hand, total iron binding capacity was considered an indication for chelation therapy. Binding of iron to plasma proteins prevent any toxicity when an iron concentration is less than the total iron binding capacity. Abdominal radiographs can be useful in confirming iron ingestion and in determining the quantity of location of undissolved iron tablets in the GI tract.
Algorithm for evaluation and management of iron poisoning. Iron ingestion, if unintentional, of less than 40 mg per kilogram, observe at home. If patients show signs and symptoms, refer to healthcare facility. If no symptoms, no treatment. If unintentional ingestion of greater than 40 mg per kilogram or unknown amount, the patient should be referred to a healthcare facility. An iron ingestion which is intentional should immediately be referred to a healthcare facility. Symptoms would include persistent vomiting, diarrhea, hematemesis, abdominal pain, and lethargy. When making referral to a healthcare facility, 4 ways should be done: gastric evacuation, abdominal radiography, iron concentration, and significant history of clinical symptoms. For abdominal radiography, if the result is negative, no treatment is required. If positive, or if pills are still visible, the patient is subjected to whole bowel irrigation. For iron concentration of less than 350 microgram per deciliter, and it shows no symptoms, first observe for 6 hours, then discharge if no symptoms persist. For iron concentration of 350 to 500 microgram per deciliter, if no symptoms, observe the patient for 6 hours and discharge if no symptoms. If symptoms like abdominal pain, vomiting, diarrhea, and hematemesis persist, the patient is subjected to deferoxamine therapy. For iron concentration of 500 microgram per deciliter, the patient is subjected to deferoxamine therapy. For significant clinical signs and symptoms, the patient should be given deferoxamine therapy and be admitted to the hospital.
Management. Initial management should focus on ensuring an adequate airway, ventilation, and circulation. Hypovolemia and metabolic acidosis should be aggressively managed with isotonic fluid and bicarbonate. Gastrointestinal decontamination or gastric lavage with large bore or gastric tube may be indicated for intentional overdoses of iron and unintentional ingestions of more than 60 mg per kilogram of iron. Whole bowel irrigation is an effective method of GI decontamination, decreasing the passage time of iron through the GI tract and thereby reducing the time available for absorption. Deferoxamine, on the other hand, is a relatively specific chelator on iron produced by the organism Streptomyces pilosus and is the antidote of choice for serious iron poisoning. Deferoxamine combines with iron to form the iron deferoxamine complex, known as ferrioxamine, which is then excreted to the kidneys and gives the urine a vinous color. However, patients who develop significant clinical toxicity, including severe GI symptoms, metabolic acidosis, decreased level of consciousness, hemodynamic stability, or serum iron concentrations of 500 micrograms per deciliter, should be monitored and treated in intensive care unit.
Guidelines for deferoxamine administration, discontinuation, and dosing. For the indications of deferoxamine therapy, the patient should have a peak serum level of greater than 500 microgram per deciliter or a significant clinical symptomatology like lethargy, coma, hypovolemia, metabolic acidosis, coagulopathy, or abdominal radiograph demonstrating significant number of pills despite attempts at gastrointestinal decontamination. Discontinuation should include resolution of clinical symptoms, absence of radiopaque pills if present initially, and return of normal urine color if vinous urine colored is present initially, and all three criteria should be present before deferoxamine discontinuation. For the dosing, continuous intravenous infusion starting at 15 mg per kilogram per hour should be given, and may titrate dose according to the severity of clinical symptomatology and the development of hypotension. The maximum infusion rate is 30 mg per kilogram per hour.